Our next speaker is Dr. Martin Kuhlmann, who will be talking about peritoneal dialysis as a treatment option for congestive heart failure. Dr. Kuhlmann is board-certified internist and nephrologist, diabetologist, and serves as director of the Department of Internal Medicine and Division of Nephrology at Vivantes Hospital in Berlin. He actually followed me as research director of RRI, and Dr. Kuhlmann.
Thanks, George. Okay, Peter, thank you for giving me the chance to speak after Chris McIntyre. You know, they're good friends. This is a real challenge because I think you all now you woke up and heard the data from Chris. Well, I'll try my best. The best thing I think you did, Peter, is to ask me to talk about PD. And Chris, you didn't mention, once you mentioned PD, very little. So, but on the other hand, I will also talk about salt and water. And I think this brings the two talks together. So let's start with this. So PD in congestive heart failure. I also start with a patient, and this is a typical patient we see frequently and you see probably frequently in your clinical practice. So it's an 80-year-old male patient who presents with volume expansion, refractory to diuretics and other medical treatment with severe congestive heart failure. On echocardiography, massive dilatation of the right atrium, right ventricle, pulmonary artery hypertension. The tricuspidal valve is insufficient, MI, with a left ventricular ejection fraction of 45%, and he has the typical comorbidities, or consequences. He has a chronic lung disease and chronic kidney disease in both stage 4. So he had multiple hospitalizations in the last 24 months before showing up, with a maximum weight gain of 30 kilograms and diuretic resistant volume expansion. 3 times he has been on ICU, 2 times continuous renal replacement therapy was used. They used inotropes and furosemide IV. Then he was released from the hospital and came back on ICU or other wards. So this time we also tried the same game again, using diuretics, IV. You see what you expect, an increase, a rise in serum creatinine, so from CKD4 to 5. So you wonder, is it enough? Or can we get this guy recompensated? So then we discussed this, and he came back and forth. So we decided together with the patient on initiating peritoneal dialysis. We did catheter implantation and a rapid start with successful weight reduction. And but not untypical, after 4 weeks he had a PD leakage, and we had to pause PD. At that time, GFR had improved, probably due to release of congestion, and GFR was at 20 mils per minute. So basically you don't need PD with 20 mils per minute, you would say. So we said, okay, let's try to do it without PD, and we did micromanagement. What does it mean? Micromanagement means to see the patient once a week at least, and to give him the option to self-modify diuretic dose, have a daily weight, and to really keep very close control with the patient. And we were able to hold the body weight stable. But you can't do this for a long period. So we restarted PD with a single icodextrin and with an average ultrafiltration of only 300 mils per day. Body weight stabilized, and so far has not been hospitalized for congestive heart failure. Sounds successful. There are many case reports on that. So let's go more into detail what to do here. What I described is the so-called cardiorenal syndrome. And Claudio Ronco and his group, they came up with this kind of classification in 5 types. And type 1 and type 2 are the ones we are referring to. This is cardiorenal, the type 3 and 4 is renocardial. and type 5 is secondary. So type 1 or type 2, what is this patient? Is this acute CRS or is it chronic CRS? To me, it's always difficult because they come acutely, decompensated, but with a CKD. So I would say this is chronic congestive heart failure resulting in CKD. Okay, so let's put it into type 2. But this doesn't help, I think. This is nice, this classification, but I think we need to, if we then see the patient, like the one I described, we realize they are differentiating into different types of cardiac failure, even in type 2 cardiorenal syndrome. So one is the arterial underfilling, and the second, at the bottom, the venous congestion. And patients differ if you look at these patients. The ones with an arterial underfilling, they have a decreased cardiac output, decreased effective circulating volume, decreased renal blood flow, activation of renal angiotensin system, and they have a low cardiac output, usually below 40%. The other ones, like the one I described, they have venous congestion and venous hypertension, raised intra-abdominal pressure, decreased AV perfusion gradient, kidney interstitial edema, and the same end like RS stimulation. But these patients, if you look at them, they have a maintained cardiac output. So we have low cardiac output patients and maintained cardiac output patients. So all within the same type 2 cardiorenal syndrome. And if you look at this, what this patient is also typical is the classical consequences. So you have an acute event, renal function, he starts with a better one, goes down, you can improve it, and it goes down again, and eventually renal function deteriorates over time. So the cardiologists classify heart failure into 3 types at the moment. So, and they are given in the middle. So do we have a pointer here? No, huh? No. So you see it in the middle line. So you see in the middle is the heart failure, it's given the left ventricular ejection fraction. In the middle it's 40 to 49%, to the right it's more than 50%, and to the left it's less than 40%. So less than 40% is the one with cardiac failure, the heart failure with reduced ejection fraction. To the right you have the one with the preserved ejection fraction, more than 50%. And in the middle you have this mildly reduced ejection fraction, 40 to 49% EF. And this is not a status, this is can have dynamics, so you can move from deterioration from one side to the other side, or to recovery from one side to the other side. But this is the basic cardiology look at heart failure. And I think we have to understand this, and we have to think about how to treat patients in the various stages of heart failure the cardiologist described. Let's go back to the pathophysiology, to the neurohormonal activation. Just look at the bottom. Here we come back to Chris McIntyre's presentation. It's about retention of sodium and water and fluid. You have an increased blood volume, you have systemic vasoconstriction, you have vascular and cardiovascular hypertrophy. So we all know this. And the consequences of neurohormonal activation in cardiorenal syndrome are listed here. You have a reduced renal blood flow, the GFR decreases, you have an increase in total body water, you have an increase in total body sodium, extracellular volume, plasma volume. The right atrial pressure increases, the left atrial pressure increases, and blood pressure may be stable or may be reduced. These are the consequences. So if we want to treat patients, as we did with that patient, what are we looking for? We're trying to remove salt and water. What do the cardiologists do? So they have guidelines, very decisively made guidelines, but they differentiate in these guidelines treatment of HFrEF with reduced EF and with preserved EF. So let's look at the guidelines, because it's interesting. The guidelines here on the patients with a reduced EF, less than 40%, they have 5 steps. First step is establish the diagnosis. Second, consider the patient scenarios. You can find these in the guidelines, including creatinine clearance, more than 30 or less than 30. Then you have the medication choices, aldosterone antagonists, ACE inhibitors, ARBs, or neprilysin inhibitors, hydral nitrates for African Americans, I think here. In black patients, it says an ICD, CRT or CRTD, or ivabradine. Step 4 is reassessing symptoms, and eventually, if it's not successful, you have additional options like palliative care, transplant, left ventricular assist device, or other studies. So these are very elaborate guidelines for the patient with a reduced ejection fraction. How does it look? What do the guidelines look like for the preserved ejection fraction? Actually, completely different, because there are almost no established treatments for those patients. You can see that they recommend to treat systolic and diastolic blood pressure. Should be controlled. Diuretics should be used for relief of symptoms due to volume overload. But then these are level B and C. They only see maybe coronary revascularization, management of atrial fibrillation, or the medication. Maybe the use of beta blocker agents, maybe ACE inhibitors, maybe ARBs. There is no evidence exactly for that. So actually there are some studies indicating that the use of beta blockers may be counterproductive in patients with preserved ejection fraction. So these patients look completely different in the way to treat them. And the cardiologists in a list, they also state here that for HFrEF, it's only in these patients that efficacious therapies have been demonstrated today. In the HFpEF, efficacious therapies have not been defined, and MREF and treatment patterns and outcome appear similar to those of patients with HFpEF. So we treat them with peritoneal dialysis if diuretics don't work, to relieve the congestion of the kidney, congestion the veins. Okay, does this really help? There's an interesting paper which came out recently, just a description of some patients. Treatment of diuretic resistance with a novel percutaneous blood flow regulator concept and initial experience. So what did they do? They used a kind of balloon or kind of umbrella, similar to ones if you have repetitive thromboembolism. So they integrated, induced them into the vena cava superior, and they opened the umbrella right below the renal veins. By that, they reduced the returning blood flow, and they relieved congestion to the renal veins, kidney veins, and probably maybe to the heart. So relieved. So they did this for 24 hours. What did they observe? And they just reported on diuresis. Look at what happened. Diuresis started. So a relief of congestion, in this case, in a short-term experiment, I would say, increases diuresis. So, okay, we are not using this umbrella, and I don't know whether this, I don't believe that this is a kind of long-term thing, but to me, this is a kind of proof of concept for the effects of venous decongestion on kidney function. Let it treat like that. Okay, so what has been done with PD in these patients? There are some case reports or some observational studies on a certain number of patients. This was one of the first ones in 2012, and one of the biggest ones with 118 patients coming from Germany. So they looked at 118 patients. The mean age was 61 years old. They had heart failure. They did not differentiate between the HFrEF, HFpEF. So it's a mix-up, as you can see. So cardiac device system was used in 32%. Ejection fraction was 43.5 from 30 to 55. and 26 didn't even have data. And the endogenous creatinine clearance was around 20, so similar to the patient we discussed. So this is a mixture of patients. What did they observe? Interestingly, in the left it says the New York Heart Association stage of congestive heart failure at start. 58 out of the 118 were at stage 3 and 60 at stage 4. To the right you have the clinical course after 6 months. 14 and 18 died. There was none in stage 4, 5% in stage 3, 50% in stage 2, and 20 or 5% in stage 1. So looks like it helped. There's a systematic review and meta-analysis of some studies published in 2015 and looking at hospitalization and left ventricular ejection fraction. So hospitalization was reduced significantly in patients treated with PD in this setup to the left, and to the right it's the outcome LVEF, and you could see that on average or as a result there's an improvement of LVEF in percentage in patients treated with PD. But there's no controlled study so far. This is all observational data. So what are the potential mechanisms favoring PD in cardiorenal syndrome? It may be the elimination of water, sodium, of potassium, other solutes, humoral factors, natriuretic peptides, IL-6, TNF-alpha, or ascites, reducing the intra-abdominal pressure. And that may result in an improvement of renal and total clearance of any solute or water, reduced need for diuretics, less risk for hyper or hypokalemia, depending on diuretics and so on. And maybe by reducing the risk for hyperkalemia, you're able to effectively block the RAAS system. So various potential mechanisms. Let's now go a little bit deeper into the elimination of water and salt in PD or by PD in these patients. You are aware of the 3-pore model, the smallest pore, the small pore, and the large pore, and you are aware of the sodium sieving effect that has been discussed yesterday shortly. And that is indicated on the left-hand side with glucose-based dialysate. And it gives you the dialysate sodium concentration as a function of dwell time. And the blue line is the lowest concentration of glucose, and the kind of reddish line or yellow line at the left, at the bottom, is with the highest glucose concentration. What does this show? It shows that sodium concentration on the y-axis decreases in the first 120 minutes with any of those PD solutions used. And this is the result of sodium sieving. That means you filtrate water by stimulating aquaporins, and it's free water without sodium coming into the abdominal space and diluting the dialysate. And the sodium sieving means the sodium remains in the filter, in the sieve. And this, then after a period of time, if you have a longer dwell time, then eventually sodium concentration may increase and may even be higher than in the beginning due to reabsorption of water over time. On the right-hand side, you see that glucose and icodextrin differentiate in their effect on sodium concentration in the dialysate. With icodextrin, you don't see this sodium sieving effect. So there is no drop in sodium in the dialysate, so you have an increase in sodium removal right from the beginning. This has consequences for treatment of heart failure patients with PD or ESRD patients with PD, because sodium removal depends on the way how you treat the patients. Let's look at this. So if you do CAPD with longer dwell times, 4-5 changes a day, you have dwell times 4 to 5 hours maybe, then you can see that dialytic sodium removal on the x-axis depends, is highly associated with ultrafiltration volume. So you have a higher ultrafiltration volume, longer dwell time, you have a higher amount of sodium removed. This is based on longer dwell times. If you do APD in the patients, typical prescription is like nocturnal treatment, exchanges every 60 to 90 minutes. So you're focusing on the short-term effect. If you're using glucose-based dialysate, you don't see an effect. So you are not able to increase sodium removal by short dwell times because you always have this sodium sieving effect. You're removing more water, less salt. And this has also been shown in some meta-analysis studies showing that sodium elimination is better with CAPD than with APD. So what about using icodextrin? What happens with icodextrin? When you use icodextrin, 7.5%, you increase ultrafiltration. You have an ultrafiltration increasing over time, up here shown 16 hours, independent of the transport type. So you see high and low and average transporters, and you see that the lines give 2 liters or 2.5 liters. This is kind of a simulation study that was published showing that you have ongoing ultrafiltration. You can also measure sodium elimination by using single icodextrin treatment, 2 liters or 2.5 liters, and sodium removed after 8, 12, or 16 hours here lies between 50 and 70, 77 with 2 liters, or 60 and 90 millimoles, milliequivalent in 60 hours for 2.5 liters. The average sodium intake we recommend to our patients would be 100 millimoles. So you may be able to remove sodium, like almost 100 millimoles of sodium with one fill of icodextrin. But that's interesting, okay, and you have to keep that in mind. There's one clinical study reporting the experience with using single icodextrin in congestive heart failure patients. It's a small number, they used all peritoneal ultrafiltration cases between 2005 and 17. It's only 15, N of 15, one patient a year, not a huge number. They used heart failure refractory to medication, contraindication against heart transplant, more than 3 heart failure-associated hospitalizations, follow-up 24 months. PD regimen was nocturnal 12 hours icodextrin, 7.5%. You see the age, 72 plus minus 9 years. You see that 75% almost had pacemaker or ICD or CRT. So again, a mixture of HFrEF, HFpEF. But they report a GFR, baseline 6 months, 12 months, 24 months. eGFR roughly stabilized over 6 months and got reduced over the next year. Urine output increased. Over time it decreased then. And furosemide dose was reduced and body weight was reduced. So it's 15 patients. So we would need a kind of randomized study to get a good idea on this. So what are other means to increase peritoneal sodium elimination? Higher dwell volumes. You have to watch out for intra-abdominal pressure, maybe not tolerated by the patient. It's recommended to increase the peritoneal contact surface area. How can you do this? By lying down. When the patient walks, the contact area is reduced. So circumbent PD, but if you do CAPD with long dwell time, circumbent probably is not that successful and not convenient for the patient. Twice daily icodextrin has been used. I didn't find a publication on that, but I think that probably can be done. Ideally, we would use sodium-reduced dialysate. We don't have this available in Germany at the moment. I don't know whether it's available in the United States. Or something like adapted PD. So who has heard about adapted PD so far? Is there any pediatrician around here? Because this has been published by pediatrics. What is adapted PD? Adapted PD is a way of kind of generating a low sodium dialysate and thereby to increase dialysate elimination. So the concept of adapted APD is the combination of small and short exchange followed by large and long exchange. So a small volume for a short time, then you have the aquaporin activation, water coming into the dialysate, reducing dialysate sodium concentration, then you are removing, like say 60-70% of that dialysate, and you leave about 30% with a low sodium concentration in the abdomen, and then you do an exchange and use a normal dialysate with a bigger volume, but you're diluting it, so you're reducing sodium content with the one that has been left in the abdomen. So the exchange favoring ultrafiltration is the short term, and the exchange favoring dialytic sodium removal is the large cycle, with the sodium-coupled water transport, long diffusion time, and high diffusion gradient. That's how a prescription looks like typically. And so 2 short exchanges, small amounts. I think it's not completely correct here at the bottom because it suggests that you have a full exchange, but something should be remaining. Okay, so this is adapted APD, has been studied in children. Can be done in humans, but needs really a very well experienced nephrologist to prescribe, and to have to train the patient, and you have to be able to know what you do. Let's come back. What are the effects of PD in cardiorenal syndrome, what we discussed? So you may reduce total body water and total body sodium. You may reduce extracellular volume and plasma volume. I think the data I was presenting to you at least suggests this, and our own experience kind of supports this. And by this, you may reduce RA pressure, LA pressure, increase GFR, and increase renal blood flow. So there are no controlled studies, but there is one. Okay, it's been published in 2019. So this is the PDHF study, peritoneal dialysis for heart failure. Multi-center, prospective, randomized controlled trial. Nocturnal 2 liters of icodextrin, 7.5% versus medical management, follow-up 18 months. You see the inclusion criteria and the exclusion criteria. The inclusion, again, it's not differentiated here. You can tell between HFrEF, HFpEF. Okay, so it's a mixture, at least in the study plan. So this was the enrollment. So they assessed for eligibility 290 patients. They excluded 280. They randomized 10 patients, 4 to PD, 6 to control. They had a follow-up for some time, but eventually they stopped the trial. Why? Because futile patient recruitment. Although they were collaborating with cardiology and nephrology. So what were the reasons for inadequate patient recruitment? In a majority of patients, GFR increased. After initiating a more guideline-based medical treatment in the HFrEF, they found increase in GFR. Frailty was another point. Inadequate heart failure therapy, okay, that could be improved. Change in heart failure guidelines, the ones I've shown you, it's an update from 2017. So, guidelines change over time. Cardiologists are doing a lot of studies. Low patient motivation for maybe accepting PD. Then interestingly, a difficult interaction between cardiology and nephrology. That goes together with a bias against therapeutic concepts. The cardiologist had a bias. They said, our cardiology approach is much better than your PD approach. And the nephrologist, looking at the same patient, said, well, we have to do PD. The cardiologists don't know what to do. So there was a kind of difficult interaction. I think this is probably reality still. You have to have a good relation and be able to define what you do. So the study was stopped, so we don't have these data. So at the end, I would like to discuss with you where's place for PD. There, in the heart failure guidelines, you could not read PD. There was no word mentioning PD in the guidelines. And here are the 3 types, HFpEF, HFmrF, and HFrEF. So where would PD fit? I think, from my experience and from what I discussed with you, I think it may fit here with the HFpEF and HFmREF, maybe better than with the HFrEF, where the guidelines give you so many options. So we still don't know. We still are waiting for a controlled trial. But I would hope that the next trial will just focus on one patient group of the heart failure types. So let's conclude. So HFrEF needs to be differentiated from HFpEF, HFmREF. Cardiorenal syndrome is clinically dominated by salt and water retention refractory to medical management, especially in PEF and MEF. PD may be used not as replacement therapy, but I would define it as a renal support to increase removal of sodium and water. This is not replacement when we do it initially, especially if you talk about a single icodextrin use. For primarily eliminating sodium and water, PD prescription needs to be different from that in ESRD, for example, single icodextrin or adapted PD. But the simple methods for PD therapy guidance in CRS are lacking. We don't know exactly how to follow up, how to measure. Do we really increase salt elimination? I think there's still room for improvement. And despite a lack of effective medical therapeutic strategies in HFpEF, HFmEF, PD has not found entrance into heart failure guidelines. So randomized studies in carefully selected patient populations are needed, and maybe Chris is able to do a study on this. He's doing so many studies. So thanks for your attention, and I'm looking forward for the discussion.